Hello and welcome. I am Monica Pica with Sachs Healthcare Communications, and I will be your technical producer for today's webinar. The title of today's webinar is Respiratory Device Pressure Injury, Know Your Accomplice. Before I introduce our moderator, Lexi Caraway, and our speaker, Dr. Black, I would like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience any technical difficulties, please use the Tech Support tab also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. Please make sure you are not behind a firewall, as this will prevent you from viewing the presentation. I would like to introduce our moderator, Lexi Caraway. Lexi is a member of the Illinois Society for Respiratory Care Board of Directors, currently serving as delegate and as Illinois PACT co-chair. She is currently the cardiopulmonary manager at Clay County Hospital in Flora, Illinois. Lexi is also a co-chair of the AARC Respiratory Care Interstate Compact Committee. Lexi has presented at several state and national conferences on the topic of thermographic imaging to detect and prevent pressure injuries. Welcome.
Thank you, Monica, for that kind introduction. The title of our webinar today is Respiratory Device Pressure Injury, Know Your Accomplice. Our speaker today is one of the nation's leading experts in pressure ulcer awareness and is a co-author of Secure Prevention Consensus. Dr. Joyce Black is a professor at the University of Nebraska Medical Center in Omaha, Nebraska College of Nursing. She has received awards from the UNMC and the college for her teaching. She was recently awarded the Joyce Black Excellence in Teaching Award from the NPIAP, named in her honor. Her research areas of interest are in wound healing, specifically in pressure ulcers. Dr. Black published the seminal article explaining the significance of pressure injury from medical devices. She is certified in wound healing and was inducted as a fellow in the American Academy of Nursing for her work in deep tissue pressure injury. Dr. Black is the immediate past president of the National Pressure Injury Advisory Panel. Our speaker has disclosed the following financial relationships. This activity has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of the webinar. Accreditation statements are below. This activity is supported by an education grant from Philips. And now I will turn the presentation over to Dr. Black.
Thank you very much, Lexi, and thanks to Philips for organizing this webinar, especially asking me to speak on pressure injuries from medical devices. It's a topic I can talk a lot about, and I will try to do my best to cover all of it, but you may end up with questions at the end. So why is it called Know Your Accomplice? Well, partly because Halloween's next week, and there's lots of murder mysteries on TV right now. But the other reason I chose that word is that we don't often think that a pressure injury can come from a medical device. Hopefully I can change your mind or enlighten you as we go through this material. I know that this is Respiratory Therapy Week, Respiratory Care Week, and I have to tell you I wore green because that's the color I associate with respiratory therapists. But I also need to tell you and thank you for the work that you do every day in caring for patients. When I was an ICU nurse, the first question I asked at the beginning of my shift, of course, was what patients am I caring for? The second question I asked every time, who's on tonight for respiratory care? Because I valued the respiratory therapist in managing those extremely complicated patients. So thank you for all those years of service and your ongoing work. So here's our objectives for today. I want to review with you the frequency of pressure injury from respiratory therapy devices. I want to look at the causes of the injury, particularly pressure, that's the big one, but shear is also a factor. And then because of the moisture accumulation between the device and the skin, something called microclimate is also a factor. But obviously the real reason I'm here is the third objective, and that's to look at the best practices to reduce the risk of medical device pressure injury from respiratory therapy devices. So the definition of a medical device pressure injury is relatively recent. We actually haven't defined this very long, but it matches the other definition of pressure injury. It's a localized injury to the skin or the underlying tissue. So these can be extensive. I don't want you to think that they're simply superficial wounds, because they're not. They come from devices that are designed for diagnostic purposes or therapeutic purposes, most commonly seen in patients in critical care. Now, the unique part of this particular problem is that the injury is pretty easy to figure out, because when you move the device, you see the wound, and the wound takes the shape of the device. So there's really no big guessing on this one. They do tend to progress rapidly, though, and I'm going to show you some photographs of how quickly these things become full thickness, because a lot of parts of the face are not well padded with fat, so there's nothing really to pad the face. And I want you specifically looking at this endotracheal tube pressure injury and the device holder. I don't want you to think that these are minuscule or minor issues. We do have patients that have such significant injury to the lip from endotracheal tubes that they end up requiring flap surgery by plastic surgery because they can't swallow, and they lose, it's called oral incompetence, if you've ever heard the phrase. Fluid and saliva just drains out of the hole in the lip from the endotracheal tube. So significant issues, certainly not minor issues by any means. So initially, these devices were called medical device-related pressure ulcer, and in 2016, the NPIAP, or the NPUAP, right, at that point in time, changed the word ulcer to injury. Why? Because 6 stages, if you know pressure injury or ulcer, you know that 2 of those stages, the stage 1 and deep tissue injury, were not open wounds. So it didn't make sense to call them ulcers. So we changed the whole group to injury, because all 6 are injuries. So when we changed the word ulcer to injury, we also changed the name of the device-related injury to medical device-related pressure injury. A unique part of the discussion that day in April of 2016 was that the audience said they felt it was important to also classify injury to the face from hearing aids and glasses as medical device pressure injury. I'm not here to debate the point. The decision was made. It was a consensus decision. So you may hear about unusual causes of medical device pressure injury. Actually, all of the words work. For me, it's most important that you communicate with me about what you're seeing and what's going on. So let's get into the epidemiology. This is the numbers game. The prevalence, and prevalence is how many patients had a device-related pressure injury when they came into your hospital, can be as high as 50%. So these are ones you didn't cause and nothing to do with you. In fact, Lexi Caraway did some phenomenal work in this issue, looking at how many people were using non-invasive ventilation at home and coming in with injury already present on the face. So of the device-related problems, we know that oxygen tubing and non-invasive ventilation masks are the most common culprits, the most common accomplice. And you can see some of the numbers. 71% of this problem comes from the devices used to support oxygenation and respiration. Sadly, in children, that number is even higher, and I have seen studies reaching 90% of pressure injuries in children come from respiratory devices. So those numbers are startling. Now, I can tell you in the hospital as a whole, about 40% of hospital-acquired pressure injury is from collectively medical devices. Within that group, the respiratory devices are the largest set of devices that we see. A little bit of background on the problem. 40 years ago, these things were called bed sores of the ear. We don't use the word bed sore anymore. We don't use the word decubitus anymore. We've flipped to the more contemporary term of pressure injury. What we've noticed, though, is as people got more ill and were hospitalized longer in critical care, both the traditional pressure ulcer rates increased, particularly in the ICU, where you guys predominantly work. And along with that, the medical device pressure injury rates also went up. Now, a couple of the issues, and we're going to get into this in a little more detail, is sometimes these devices are life-saving devices. So it's not like you can pull the endotracheal tube because the patient has a wound on their lip. I get that. And that makes it a little more complicated to think about prevention and treatment because you can't just take the device off. I can't extubate the patient. I can't pull the trach because they're ulcerating. I have to figure out another way around it. On top of that, because the airway is number one, right? The A in ABC is airway. Because the airway and breathing are such crucial components to the health and survival of patients, sometimes these devices are secured too tightly. And when we have patients, particularly those that are in sepsis, they get fluid resuscitated, as you know. Their tissues swell, and the device that once was appropriately secured is now too tight. The other problem that we have, and this is nationwide, not every device comes in every size, and not every hospital has every possible option. So I know that you're limited, and I am going to push you at the end of this lecture for how you can get involved in the proper choices of products. So the other place that we talk about medical device injuries on the mucous membrane, and the one that you're going to see the most often is the mucous membrane of the lip. You certainly will see some people have nasal intubation, and they can get pressure injury not only on the nares at the surface of the nose, but internally in the nose itself. Those are very difficult wounds to treat. We do ask, though, that if a patient has a pressure injury on mucous membrane, that it not be staged, because anatomically, a mucous membrane is not the same as skin. But again, like I said earlier, that does not mean they're not insignificant. So that's a bunch of negatives in there. Mucous membrane pressure injuries can be a significant cause of harm to patients. So just because it doesn't have a stage doesn't mean that it's an insignificant wound. I think I went through 2 slides there. There we are. We look again, a little more detail on the numbers. Mucous membrane pressure injury predominantly in the ICU patients. So majority of you work in that arena. So you see these patients, and you can see that they're not common. This is a broad-based picture. So 11 injuries in 10,000 patients. So when you see that number, you automatically go, well, that's not a big deal. I'm going to hope to convince you elsewise. In the ICU, much more common, 2.4%. The time from intubation until ulceration was around 3 days, and many of those tubes we know were not moved in that 3-day period of time. Most commonly the lips, sometimes internally in the mouth were the locations of the wounds. As I said a couple of minutes ago, pressure injuries in children are almost always due to medical devices and almost always due to respiratory medical devices. So you see the pictures here, you see the mask on. It's compressing the nose and injures the columella, which is the little piece of tissue from the top of the lip to the tip of the nose. And these kids don't have bones. I mean, this is all cartilage, so very moldable tissue, leading to facial deformity, particularly of the columella, requiring plastic surgery for repair. So hopefully now I've convinced you of the seriousness of the problem. Let's look at etiology. Pressure is the leading etiology, and as you can see in the drawing, the arrow pushing down is pressure. And what pressure does is compresses the skin and compresses the blood vessels to make the tissue ischemic. That's the classic pressure injury. Medical device pressure injuries can be of the deep tissue injury style. And in that instance, the pressure is so intense that it actually puts the muscle at risk and injures the muscle. It actually fractures the muscle cell. So if you're used to the condition of rhabdomyolysis, that's what deep tissue pressure injury is. So in our ICU patients is where we're going to see this. And what we see it in ECMO patients, we see it in patients that have orthopedic multi-trauma injury. And of course, we do see it in non-invasive ventilation systems, particularly on the nasal bridge. And I'll show you a picture of that in just a second. Let me make sure I didn't miss my, nope, I didn't. My slide mover is a little sensitive. So the other piece of the story now is the microclimate. And by definition, microclimate is the humidity, the temperature and moisture between the medical device and the skin. It's very small space. I'll give you that, very small space. But the problem is that the moisture coming from sweat, coming from exhaled gases, and the moisture within the lung absorbs into the skin. And so this is not unlike what happens to you when you sit in a hot tub and your skin smells like chlorine. Your skin absorbs the fluid of the hot tub. So when there's fluid in that space between the mask and the skin absorbs that fluid. The skin then becomes boggy, and that boggy skin does not tolerate pressure and shear. Then on top of that, as the temperature rises, so if the patient's febrile or the mask gets hot, the metabolic need of the body goes up for every temperature rise. It's a Celsius temperature rise. So every Celsius degree rise, the metabolic need goes up by 10%. That increases the need of that tissue for blood and oxygen, but that cannot be delivered when there's pressure compressing the blood vessels. So microclimate might not seem like a big production. All you have to do is lift the mask and dry the skin, but it is a significant aspect of injury. So moving to the devices itself, what actually causes harm? I want to start with the more simple diagram. And what this first diagram is looking at is if you have a small contact area on the patient's skin, it isn't going to take much pressure to harm the patient. So I want you to think about putting your hand on a nail. That's a pretty small contact area. And even if the nail was dull, it's not going to take much to harm the skin. So that's a small contact area, the size of an oxygen tubing, for example, or the pressure exerted from a pulse oximeter on the ear. Now move up the line. Let's say that we have a larger area of contact. So this is an NIV mask. You've got a larger area of contact across the whole face. It's less likely to cause serious harm because you've distributed the pressure all the way across that tissue. So this is why people can lay on a bed of nails, is they're stretching out and exposing a greater area to all the different points. The right side of the diagram now says, what if we alter the tolerance of skin for pressure through microclimate? Well, then it doesn't take as much force to injure. Now, I think you're going to find this next diagram kind of interesting. You saw a peek of it just for a second. This is, to me, it's a very complicated drawing, but let me walk you through what Emmett Geffen is trying to tell us in this story. What he was trying to do is look at all of the medical devices that he was seeing. As a bioengineer, what devices he was seeing and how stiff they were, and what that relationship of stiffness is to pressure injury. So what he's described here is an elastic modulus, and an elastic modulus is simply a numeric expression of stiffness. That's all that word means. So now take it to the device itself, or the chart itself. You can see on to the left of center is something that says dressing number 1 and dressing number 2, and then there's a bracket, and right above it, it says range of elastic moduli of human skin. So he has got the 2 dots on the line, and he is saying that's the stiffness of human skin. Some skin is thicker and therefore stiffer. In older people's, skin is quite thin and does not have much elastic recoil to it. It therefore is not stiff at all. It's flaccid. So that's what the blue dots on the line mean, is there's the range. So if we have a device, a medical device, that fits within human skin stiffness, there shouldn't be any harm from that device unless it is used for an extended period of time. Now let's look at the numbers. So starting on your left, TH2, down at the bottom, you'll see that's an endotracheal tube holder. That's a foam front anchoring support device. And itself, in and of itself, is not a high pressure device. You see it sits within the elastic recoil of skin. Number 4 is the trach collar. So going around the back of the neck, not particularly stiff. I'm going to jump now up past the range of human skin. And you can see, now we're going to look at mask number 1 and TH number 1. If you go to the little thing at the bottom, TH number 1 is the endotracheal tube holder that has anchors up on the cheekbones. That thing is stiffer than human skin and likely to cause harm. Mask number 1, he called a BiPAP mask. I realize it's got a different name now, but you know what it means. That mask is, the plastic within that mask is stiffer than human skin. As you go across, you can see all the various things that are used on the face for the delivery of oxygen, except way at the end, you see T number 2. That's the nasogastric tube. He called it a Salem sump. You know it as a nasogastric tube. That is the stiffest plastic of any plastic that we use. So what is this map showing us? It's showing us that all but 2 of the devices used for the delivery of oxygen exceed the elastic properties of human skin. So it's not surprising that we're getting wounds. So how do pressure injuries from medical devices compare to the run-of-the-mill pressure injury? The run-of-the-mill pressure injury is one that is caused by the body being compressed on a mattress. And so the picture you're seeing is a patient with multiple sclerosis whose wheelchair cushion had collapsed. And you can see she has a pretty significant wound on her ischial tuberosity from sitting on that collapsed wheelchair. Very typical story of pressure injuries on the body is there wherever the body comes in contact with a pressure device. So it's the wheelchair cushion, the heel on the bed, the butt on the bed. So these are different in that we can directly associate it with the device in use. I apologize for my mouse being, I tried to set the sensitivity of my mouse this weekend, and of course I don't think I did it correctly, right? So what I put on this picture for you, and please use this one if you need it for teaching, I'd be happy to share it. These are all the stages of pressure injuries from oxygen delivery devices, respiratory devices, going from stage 1 all the way up to stage 4 on the top row. And then the bottom row is the unstageable, a deep tissue injury of the ear, and then a mucous membrane injury. So we're going to come back to the guy with the unstageable pressure injury, but he is who I was referring to a few minutes ago when I said I'm going to give you an example of how significant these injuries can become, particularly when they're on the face. So as Lexi said, I was really pleased to be part of an effort. This was during COVID, so, what else could you do, right? There was an effort done to try to look at how many pressure injuries were occurring from medical devices. This document came out of Europe, and Europe uses the word pressure ulcers. So you'll see that through the there's 2 manuscripts, 2 publications. So this was a multidisciplinary group of folks that got together to really talk about how serious these problems were, what they were coming from, and how to prevent them. Published COVID years, right? 2019 and 2022. They're phenomenal documents. They should be part of your library when you're thinking about what should your system be doing to prevent these injuries. So one of the things that we need to think about when we're trying to organize a plan, and this comes from the secure document, is make sure that you select a mask that does not come in contact with the nasal bridge. The nasal bridge is the part of the nose that is bone up near at the juncture to the forehead. Nurses and the rest of the team, we really need to work with respiratory therapy to make sure it fits right. And I think one of the, I hate to call it a mistake, I think we were taught this way. We were taught that these products need to be airtight. You cannot have a leak. The seal has to be tight. And so we were all taught to pull those securement straps about as tight as you can get to make sure that there was no leak. Well, you know what we're finding out is that really wasn't right. Obviously, you don't want a large leak, but a small leak is okay. However, I think the best thing that we have learned and tested is to apply a preventive foam dressing to the bridge of the nose as soon as you can, hopefully before you start the therapy. Because obviously, once the patient is in those devices, you don't want to take them out all the time just to put the dressings on. So important, very basic first piece of the story. So what's the prevention plan for kids? I think the prevention plan for kids, and probably for adults as far as that goes, is alternate the type of mask. And where I think nurses are going to need the most help is when a patient is on a face mask and it's time to eat. They need to be placed onto a nasal cannula. You and I both know that. But the thing that is cumbersome for some people is they don't understand how to convert the FiO2 that you have in the mask to liters per minute in a nasal cannula. So when you work with folks, be sure you're very clear about that as you well know, and I put it there for any nurses listening, 4% equals 1 liter per minute. So that should help make those adjustments. The other thing you need to do, though, is recognize that pressure injuries cause pain, and so you can ask about pain in the face. You may not easily see early changes in the color of the skin. Now, I think an important thing, particularly for respiratory therapy professionals, is alternating the type of mask. And so here's a great plan, a rotation system, if you will, where you change from a total mask to an under the nose mask, and you alternate the location of the pressure, the location of the microclimate, and rotating the mask reduces the time of pressure and shear on the tissue. So this is a fabulous way to do this. I would encourage you to be prescriptive in its process. This is not going to be natural for everybody that you're working with. So get a plan in place, write the times down, write the specific mask that you're using, what the settings are, if it's cannula versus mask, just to make it easier as you go forward. So the secure prevention document said some other things to kind of help you. Hang on, I think I'm off here. No, pardon me. Okay, the secure prevention, I'm sorry. The secure prevention document did look at the whole process of pressure injury prevention and basically concludes what I think we all believe, that medical device pressure injuries are reasonably preventable as long as you follow a reasonable practice. The devices need to be properly sized, and that's going to be true across the board for every medical device. You need to secure them. We get that. That's why the document was called secure. We need to secure the device to make sure it's properly working, but not so tight that it's leading to injury. Any medical device of any kind needs to be used for the least amount of time mandatory. And then when it's not going to be possible to use the device for a short period of time, put a thin foam dressing under the device. You don't want the foam dressing to be so thick that it causes more pressure onto itself. And then the patient shouldn't lay on the device. Seems to be logical, but sometimes it's not always logical, right? So here's the plan for the adult. Rotating the type of mask that I already talked about, using that preventive dressing. And then for the non-respiratory therapists in the audience today, you need to work with the nurses to make sure that the fit is right. Particularly respiratory therapy is not, you well know, you're not there every minute of the day, and particularly outside the ICU. The nurses or aides or techs need to know how to use those devices, how to use them safely to make sure that it's working. So when we're talking about kids, a little more complicated to get this done right. You need to check the spacing between the skin and the straps as you strap it to the child's face. This is harder because obviously they're much smaller people, so it's hard to get the fit right. The nasal prongs should slide into the nares, that's the hole, the external hole of the nose, but not push the nostril out. We see a lot of kids after use of nasal oxygen where the nare is extremely large, and the parents, of course, are frightened by that look. Most of the time, it will shrink down, but depends on how long it was used. As we were looking at a little bit ago, be sure that the device doesn't flatten the face, press on the columella, do other things, because those changes from the mask and the securement of the mask can lead to permanent harm requiring surgery. You need to center it on the nose, face. You make sure that it does not touch the eye or the lip to make sure that it actually is centered where you want it to be. The air leak in some of these masks can dry out the conjunctiva of the eye and lead to some problems with eye injuries. So we want the leak not to be blowing air up on the eye, obviously. And you can get nasal irritation if you're using the nasal prongs. They can really irritate inside the nose, leading to furuncles, all sorts of problems with little cysts inside the nose. The cheeks should not be visibly indented, and all those are good pieces of advice in how to fit that mask, or other device, I should say. All right. My mouse again, overly sensitive. So let's look at some specific plans on how to approach these people. So we've got the delivery devices, including the trach collar and straps, the NIV mask, the nasal cannula, the endotracheal tube, here's some issues that, of course, you guys know pretty well. Everybody's face is different, so that's why the mask should have enough flexibility that it can fit these irregular contours. Because airway and breathing are number 1 and 2, there's a great deal of urgency to place that. And what we found worked really well is that we put the preventive dressings in the ER so that the respiratory therapist did not have to wait for the nurse to come by with the dressing, watching this patient desaturate this whole time. There is a desire to have a tight seal, but that's really overestimated, I think. So let's look at the pictures. Up in the upper left, that's a patient. You can see the trach, obviously. That's a patient with a wound from the tie. That wound eventually eroded through the jugular vein, and that patient hemorrhaged and died. On the upper right, that's a patient who was waiting for liver transplant, came into our ER. You can see the jaundice is obvious, so he needed a liver transplant, but he was in pulmonary edema, and he had a do not intubate order. So he was fitted in the ER with non-invasive ventilation mask, and that is his nose the next morning. There is no fat and very thin skin on the nose, so he has an unstageable pressure injury of the nose. I remember talking to him. I remember how angry he was because he'd actually gotten up and looked in the mirror in the bathroom because of the pain in his nose, and he wasn't accepting of any explanation that I offered about he was in respiratory distress and we had to do something quickly. Fortunately for us, plastic surgery was able to debride and close it. The patient on the bottom left was the very first patient we ever had with a medical device injury, period, that we knew of. This was a guy, pretty simple case, right? He's on nasal cannula, but what we found was happening is even though he was comatose when he got turned in bed, the nasal cannula came out of his nose. And the nurse's aides decided that the way to fix that was to put the nasal cannula back together and move the lariat up nice and tight so that it wouldn't fall out of his nose. And so you can see that. I've got more pictures of him, but let me tell you that the wounds from the oxygen tubing were throughout his face. You can see on the jawline, they were behind his ear, they were up on his cheekbone, all of that in an effort to keep the cannula in place. And then the patient on the bottom right, very clear endotracheal tube device. You can see the holder for the device was a common one. I think it's a common one for a lot of us, and has its own set of problems, particularly in prone patients, which we'll talk about in just a second. So what does the secure document say about how to prevent pressure injuries? It says match the device to the size of the patient. It says consider that elders with thin skin and children with undeveloped skin, particularly neonates, are very high risk of ulceration. It says it's important to protect the skin under the device with a dressing. And then I put in bold and italics, move or remove the device daily to see the skin. I can tell you that's going to be a bump in your practice. I can tell you when we get done today and you try to go back onto the floor and say, hey, we need to move or remove these devices every day, you're going to get pushback because not every device is easily moved. When somebody has a tracheostomy and is agitated, I'm going to be a little hesitant to take the straps down to look at the skin of the neck. That's where you come in. We've got to do this one as a team. Not every device is easily moved or removed, but that allows us to catch the pressure injury a lot earlier and make the treatment a lot easier. Edema makes the tissue more likely to be harmed, and in bariatric patients, there are devices, particularly the trach ties, that get lost in the folds of the neck. So be aware of that when you're going to have to do some hunting to find that device. So one of the things that we certainly all struggled with was the care of patients during COVID. And I just wrote a chapter on this, so I thought I'd share some of this with you. I looked at the research on pressure injuries during COVID and, of course, got stuck on the prone patient. And what I found was there was a hospital that wrote about their experience with the prone patient. Their rates were 250% higher in patients with COVID that were prone. They found pressure injuries on the anterior body surfaces because, of course, they're not padded. And that ET tube stabilizer that I talked about just a second ago cannot be used on patients that are prone because the pressure is too intense on the cheekbone. They need to be put into twill ties. And during COVID, some of you were aware of how to tie an ET tube with twill. Not everybody was. And so there was a great deal of worry about extubation in the patient prone, but they do have to be secured differently. So when the patient is prone, the wound on the top is what you get when you use the holders when you flip the patient over. So stabilize it with twill tape like you see in the picture. You might have to practice this, and so I know there's a couple YouTube videos, and there are some commercial products available, but do not use the ET tube holder. That's great when the patient's supine, just won't work when the patient's prone. So oral mucous membrane pressure injuries. Here we go again. Airway is number one. What do we do to prevent these? The tube has to be repositioned or rotated, and my recommendation for practice is that each time the patient is turned in bed, which should be every 2 to 3 hours, move the tube because you're going to have to move everything anyway. So rotate the tube from one side of the mouth to the other. Alternate if the patient's on not an endotracheal tube, but the other devices. Alternate the device. See if you can loosen the securement, and then I already talked about the ET tube holders simply don't work. For oxygen tubing ulcers, it's important to look at the patient closely because these devices slip out of the nose, and it is hard to keep them in place, particularly in patients who are agitated. So we do need to look behind the ears. Our hospital has found some good results with using silicone oxygen tubing. I'm not here to market it, but we have found better outcomes with silicone than plain plastic. And you can see the wounds can be significant. Look at the necrosis on that guy's ear. It did go ahead and fully necrose and then eventually heal, but he had a significant scar nonetheless. So one of the things that we see in kids, and here's some photographs of kids with injury, is the significance of the injury. These are babies, and so it's very hard to explain to the parents what's going on and whether we believe these things are recoverable or not. We don't tend to see, as you can see, I put my favorite patient up there again on the right. We don't tend to see that level of injury, but the parents are concerned, and we cannot always predict how much of the injury that we see from direct pressure is going to be recoverable without permanent physical damage. So be sensitive to that because these are our babies. Obviously, the guy with the nasal bridge problem, we could speak to him. So some options to look at when you're looking for a mask. Try to find one that doesn't have contact with the nasal bridge. As we said, rotate the mask, put the devices on. My word to nurses in the audience, work with the respiratory therapist. Second question I ask, who's the respiratory therapist on duty tonight? I need to know that because I don't know everything I should know about respiratory devices. So be sure that you're working with them. So trach collars are kind of a difficult problem, and the trach flange itself. The faceplate is often sutured at the time of the operation, and then it swells. And the trach ties are tied very tightly to make sure the trach does not come loose. And for the first 4 or 5 days, there would be significant risk of loss of the airway. But after that period of time, the risk is less. So obviously, as I said, the obese patient, you can lose the ties, and you're sitting right on top of the carotid and jugular. So if there's erosion, as in the top picture, that was fatal for that patient. So prevention for these patients, thing that we found that really worked the best is to work with the doctors who place the trach to see if we can take the sutures out at 5 to 7 days. Many times the doctor who put the trach in was only there for that purpose and doesn't necessarily come back. So you have to kind of chase them down. We actually had a team meeting about this. So we got a set of routine orders that at day 5 we could take the sutures out. There are more flexible trach tubes. There are better holders. You can see a great picture of a holder, a trach holder that has a wide strap and would be less likely to cause injury. You sometimes can place dressings during surgery that will pad particularly the area right at the phalange. Now, for respiratory therapy, it's your job to work with nursing on how these are secured and how the trach ties can come down. This is the one that we really need your help on, because not a lot of people are going to be comfortable stripping the whole system down just for trach care without a second person around in case that patient gets agitated. So the pulse oximetry may not be something that you put into your wheelhouse as a respiratory device, but obviously the two go together. The metal clips that are used to measure pulse oximetry of the ear, the pressure is unbelievably intense. Nice little article of a while ago where Goodall measured the actual pressure at the skin interface. The problem is the peripheral monitors don't read particularly well, so the ones out on the finger. So we do tend to use these on the ear because they're more accurate, but the pressure is high enough that it leads to significant harm. So again, move the device each time the patient is moved in bed. Yes, there'll be a lag, and when the oximeter comes back to be giving you a good reading, but you should move the device to not end up with injury that I show you in the picture. So prevention, you can use foam devices around the nasal cannulas. Problem I find is they fall off on the floor. Avoid pulling on the lariat. That we learned that lesson the hard way. Silicone tubing, rotate the mask. I'm watching my time, so I think we've talked about most of this stuff. So medical device pressure injury prevention has a nice long list, things for you to work on, but I think they're all accomplishable. So the secure document that I mentioned a little while ago did break it down in each of the letters. So we were talking about a secure system, but we also broke it down. So the S stands for skin assessment and tissue assessment. The E is making sure everybody's fully educated. The C, all of us need to be champions. All of us need to collaborate. We need to understand why these injuries happen, because that allows us to devise the proper care. We need to make sure that we're reporting them to the system to make sure that we have change, and then evaluate. So did we change systems? Did we change turning? And what did we get for an outcome? So as I wrap this up, I do want to just kind of bring your awareness to a couple of issues. And one is, are you reporting the injury from the medical device to the manufacturer? I find it doesn't happen consistently. So what has happened since manufacturers have been notified of these devices is the neck collar for neck fracture has been extended so we don't get occipital injury. We've got silicone oxygen tubing, and the non-invasive ventilation mask has been re-engineered. So the manufacturer listens, but somebody has to talk. And so that's That's your role. We've got to speak up because the patient can't speak up. So what I want you to start thinking about is examining medical device pressure injury in your hospital. And here's what the data needs to include. What was the actual device? Who manufactured it? How many days was the patient using it before they got a pressure injury? And then within that period of time, how adherent to a bundle of care was the staff? So you're going to look at the medical record. Was the device rotated? Was it the right size to start with? Was the device changed? What did you change from one type of mask to another? Was there padding on the skin? And was there documentation that the skin was assessed on each shift underneath that device? So one of the things I want to bring up briefly, and it's probably a 3-hour lecture onto itself, starting in 26 or 27, depending on what your hospital chooses, CMS will automatically draw patient data from your charts to identify pressure injuries present on admission. Admission, according to them, is when admission orders are written by the physician. So if this patient's in the emergency room, when the admission orders are written, that's when the clock starts. And the condition of the skin at that time will determine present on admission, that it will include all stages except stage 1. So this is a big change, and I want you to be ready for it. So what does this mean? This means if a patient comes into the ED or pre-op and is admitted, somebody in those areas has to examine the skin. Are people in the ED having their skin examined? Not in my experience. Do people in the ED and the pre-op know how to stage a pressure injury? Do they know what isn't a pressure injury? Because the wound nurse coming in 2 days later isn't going to be able to fix the problem. One of the things that Lexi Caraway studied was how many people already had pressure injury when they came into the hospital on the face from non-invasive positive pressure. So the next thing that's going to be important for your hospital is that stage 2s are going to be included in this reportable event. And so what I put in was a bunch of pictures of stage 2. You're going to need to be educated as well as your staff on what stage 2s are, what they look like, what they're not. And so you can see they tend to be superficial. Sometimes you can see skin remnant. In darkly pigmented patients, you tend to see quite a bit of skin remnant. Stage 2s will be included in the new electronic quality measure. So expect to hear a lot of commotion about that. I know it's going to be there. So to wrap this up, and I apologize, I'm only going to give you a few minutes for questions. Don't underestimate the significance of these problems, be it on the skin or mucous membrane. Recognize your accomplice. Oxygen delivery devices are the major medical device leading to tissue damage. So respiratory therapy plays a significant role in how we're going to reduce the problem. Be part of the team. Move the device when you see the patient and improve the system. If you have a group of devices that you know right now lead to harm, change the system. Get something new. Well, let me thank you for the opportunity to present to you today. I appreciate being able just to share the story of medical device injury. So I'm going to turn this back over to Lexi Caraway, and we'll spend the last 5 minutes or so doing questions. Thank you.
Thank you, Dr. Black, for an always very informational topic. I would like to inform our viewers here in just a second how to obtain their CEs. But first, we want to, again, thank our respiratory therapists. And I would like to personally wish all my colleagues a happy Respiratory Care Week. This activity has been approved for 1 contact hour. You can obtain those continuing education credits by logging into www.saxtesting.com/BO. You will need to register on the test site and then complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. This activity is supported by an education grant from Philips. An archive on-demand version will be available on www.betteroutcomesnow.org, and the on-demand version will be accredited for CEs. So now we have a couple questions we can get to here. This one I really like, and I struggled with this myself in the beginning, so I think it's important to be asked during this. Is it acceptable to place a barrier such as Mepilex or foam directly over an early pressure injury?
Yes, the answer is yes, but most importantly, you need to get the pressure off of it. So the foam dressings are a great way to protect the skin from future harm from shear and ongoing pressure. But the most important thing you can do is get the patient off of it. So if it's a heel, get the heel up. If it's a sacrum, get the patient turned. If it's a medical device, move the device, change the device, do something. The dressing can only do so much, but yes, it's a good start.
Okay, thank you very much. This is a question about neuro patients and the tongue. How would you approach injury to the tongue with neuro patients? The question, it says, I've seen an increase with our intubated neuro patients having injuries and tongue swelling. I thought that was an interesting question.
So it sounds like the person is saying that the ET tube is leading to injury on the tongue, so they're actually ulcerating the tongue is what it sounds like, rather than biting the tongue. That would just wanted to make sure that these weren't seizuring patients and injuring their tongue that way. It's the same process, is just moving the tube from one side of the mouth to the other. If you see the injury, let's say the injury is on the left side of the tongue, then write an order that says do not place ET tube on left side of mouth. Get ET tube only in the center or to the right. That's going to be the only way, short of putting a trach into the patient. Tongue injury does commonly heal and often heals without scar. So that's the good thing.
Okay, and I think we're going to do one more question here. I think this is a really important one and definitely a hot topic. So recognizing pressure injury early is obviously very important. Do you have any specific tips for recognizing stage 1 injuries or just early recognition of pressure injuries on darkly pigmented skin versus lightly pigmented skin?
Boy, that's the question of the hour, isn't it? There's a staging of skin tone, so let me give you that first. So people who you might say are Caribbean or Middle Africa would have the darkest tone of their skin, and you cannot see stage 1 or deep tissue injury in those patients. It is not possible because the pigment is so heavy that it blocks you seeing the skin. Now, there's a couple FDA-approved devices that do work. There's one that measures subepidermal moisture. It's been approved for the sacrum and the heels, so that would not help you with respiratory devices and injury. But there's another one which measures the temperature of the skin, and it gets its temperature from blood flow. That device is approved to measure everywhere, and that would be the one that would give you the earliest sign of ischemia or inflammation in tissue in any color. Thermographic image is colorblind. It doesn't care what the color of the skin is. Lexi, I think that's what you used, right? Was you looked at faces with thermography?
Yes, that was one of the ways that we were able to prevent pressure injuries from advancing further.
Right. Lexi presented at the National Pressure Injury Advisory Panel meeting either last year or the year before, and it was spot on. It was exactly this question of how do you catch these early? And I think, if I'm going to quote you now, but I'll be wrong, the number of people who use non-invasive ventilation at night at home is rapidly increasing. So there's a number of these patients who probably treated themselves at home before they came in that have pre-existing injury. I think that was your premise, wasn't it, Lexi? That was great work.
Yes.
It's great work.
Well, thank you very much. I'm going to go ahead and turn this back over to Monica for some concluding remarks.
Thank you so much. Immediately upon conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open. We appreciate your feedback. In 1 hour following the conclusion of this webinar, you will receive an email with the instructions and this link to obtain your CE credits. And once again, that link is www.sextesting.com/BO. We thank you so much for attending this webinar and have a wonderful day.
Bye now.